Okay. So for evaluation of pelvic organ prolapse, what history patient will present with either a vaginal bulge or a lump down below, and it may be associated with urinary bowel or sexual symptoms. On examination, you will see a pelvic mass or any pelvic pathology. You have to do a POPQ staging. You have to assess for the pelvic floor muscles. You have to assess because vaginal atrophy is one of the cause, and you have to examine the patient in all positions, squatting, standing, and sitting. So this is cystocele, where the anterior wall, the bladder is prolapsed into vagina. This is rectocele, where the rectum gets prolapsed into vagina. This is the prolapsed uterus or apical prolapse, where the uterus comes down. And this is a vault prolapse, where the uterus has been removed and the vault comes down.
Okay.
This is how it is. How do you manage now? So first line is a lifestyle modification. If the BMI is more than 30, you ask them to lose weight, minimize lifting heavy weight, prevent or treat constipation or chronic cough if it is there. You give them topical estrogens in case there is vaginal atrophy, or you can also give them estrogen releasing ring, or you can offer them cognitive or which is particularly effective for physical impairments. If there is dryness and all that, then it might help. Then you can teach them pelvic floor muscle training. It should be supervised, and you have to give advice for it to be effective. You have to advise it for 4 months or 16 weeks.
Okay.
Particularly for stage 1 and 2 prolapse, and in case it is beneficial with alone PFMT, you can continue.
Okay.
Then the next thing is, in case the patient is not responding to all this, you go for pessary. Pessary is indicated for females who are not fit for surgery or who refuse surgery, or if the patient is pregnant or doesn't want any surgery and wants to have children, or in fact nowadays it is a first line for any kind of prolapse.
Okay.
So there are two types of pessaries. There are support pessaries and space filling pessary. Support pessaries are ring shell. These are like a ring. So these are particularly helpful in patients who are sexually active. And space occupying, which occupy the space, like Gellhorn pessary, donut pessary, cube pessary. So these pessary are used for females who are not sexually active.
How does ring pessary helps?
So it will just keep the vault in place, no? It will shift the uterus up.
Okay.
Okay, or cervix up. It is particularly helpful in uterovaginal prolapse.
Okay. Wall prolapse.
Compartment, apical compartment, and sometimes for cystocele also. In case there is this Gellhorn, they have, or donut pessary. So they also keep the cervix in place.
Okay. This ring cannot be used for cervical prolapse. Only for the wall prolapse.
No, for cervical prolapse also you can use it. No, it will keep the
Ring
cervix in
pessary, but how cervix will fall inside that ring?
No, it will insert this ring inside the vagina, which will push the cervix up
Okay.
and the uterus up.
Cervix will not protrude inside this.
Yeah.
Into this.
No,
It
no,
will.
it will fit. It will be a ring, and it will just push the part which is coming down.
Okay.
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 So you have to give these pessaries along with the supervised pelvic floor muscle training. In case there is vaginal atrophy, you also have to offer them topical estrogen, and you have to explain the patient that more than one pessary fitting may be required, because sometimes one size doesn't fit all. So you have to assess the size, and sometimes people might need to change the pessary in case it is not fitting properly. Complications include vaginal discharge, bleeding, difficulty moving, or expulsion. Contraindications to using pessary is if there is active genital infection, vaginal mesh erosion, or if the mesh is inserted, or if there are medical or social reasons which cause the women not to be compliant with the follow-up, because follow-up is very important after inserting the pessary, or in case there is latex allergy. In these cases, you can use special silicone or vinyl pessary.
Mesh will be inserted for prolapse
For
also.
either for prolapse or for SUI, in case it was done. because both of these are source of infection. Then how do you follow up these patients? So first follow up, you call them after 2 weeks and you check for any bleeding, pain, discharge, and examine her to remove it and clean it with soap and water. And you examine the vagina for any pressure points or ulceration. If everything is good, you teach them how they can remove it themselves and how they can clean it. And in case they learn it, you ask them to do it every week, and then you call them after 2 months, and then every 6 to 12 months. Suppose if the patient is not able to change the pessary and not able to clean the pessary, then you have to call them every 2 to 3
So it's
months.
like a cervical cap or diaphragm only.
Yeah.
And if a patient has mess already, like why we are not going for a pessary? Because we don't want to add the infection.
Yeah, because both of these are foreign, and plus it further cause exposure of the mesh.
Okay, and so the treatment will be
Surgery. The last resort is surgery.
okay.
Okay, so surgery, indications of doing the surgery if the symptoms have not improved with the conservative measures, or if the patient has declined the non-surgical treatment. So if the patient is willing, you have two options. Patient has completed surgery and she's willing for vaginal hysterectomy. You do vaginal hysterectomy. In case there is associated anterior prolapse, you do anterior colporrhaphy, and posterior prolapse, you do posterior colpoperineorrhaphy. And you take additional measures to prevent wall prolapse. I'll be telling what all, because after doing this vaginal hysterectomy also, the uterus is supported by certain ligaments like uterosacral rod, which keep the uterus in place. So when you remove the uterus, you clamp, cut, and ligate these ligaments. So there are chances that in 1 in 200 patients, the vault can come down.
Okay.
So in order to prevent that, you have to do additional steps while you're performing the surgery. I'll be telling you what you do for that. And in case the patient is not willing for vaginal hysterectomy, then you do conservative surgeries like Fothergill's repair, Manchester repair.
Okay.
Okay, so in case if you get a question like the patient is young, family not completed, and she is keen for childbearing, then you do reproductive function conserving surgeries. And in case patient is elderly, she has completed family, and if she's not keen on childbearing, then you go for vaginal hysterectomy along with additional surgeries.
Okay.
Now, what is this conservative surgeries? Fothergill or Manchester operation. It is for obviously advanced prolapse, like second or third degree prolapse. In this, what you do, it is a choice in uncomplicated uterovaginal prolapse when the uterus is to be preserved. Principles of the surgery include: you amputate the cervix here, shorten the you basically tighten the McEnroe's ligaments. You do, in case there is cystocele, you do the cystocele repair. In case there is rectocele, you do rectocele repair. And you do DNC because you don't want pregnancy to occur until the healing is complete.
So this is for second or third degree prolapse.
Yeah, and this is conservative thing.
Okay.
Limitation, because you are amputating the cervix, so it can result in short cervix and incompetent os, resulting in habitual abortions,
So
preterm delivery, cervical stenosis, dystocia during labor. All that can occur.
what is
Okay,
that? DNC is a must.
you clean because you don't want pregnancy immediately, you know.
Okay.
That's why for healing
Just to
you
check
also
the
do.
endometrium.
Okay, so you dilate the cervix here, do anterior
DNC
wall.
is must means even in negative cases.
Yeah, because
Okay.
even if you've not done it and she continues to bleed, that also will impair healing, no?
Okay.
For some time you do DNC,
Okay.
and in order to prevent stenosis also later on. So dilatation of cervix you do, then anterior corporography, then you shorten these McEnroe's, amputate the cervix, then suture these cardinal ligament in front of cervix. Basically, you tighten these cardinal ligaments so that the uterus, basically because of the laxity of these ligaments, the support, the uterus, there was cervical elongation which was happening. So when you tighten it and shorten it, the uterus is held in place.
Okay.
And then later on you can also reform the lips of the cervix using the vagina. So this is an optional step. Okay, now what are the preventive techniques at hysterectomy which you can do in order to prevent wall prolapse later on? So if you're doing vaginal hysterectomy, you can do mecal caldoplasty. It prevents the development of enterocele, and it is more efficacious than vaginal Moscovitz or simple closure of the peritoneum. It involves approximating the uterosacral ligaments using continuous sutures so as to obliterate the peritoneum of the posterior cul-de-sac as high as possible. So this is how it is done. So you take these Meckel sutures. So these are the uterosacral ligaments. So once you remove the uterus, okay. So there are you cut, clamp and ligate the uterosacral and cardinal ligament. The stumps are available. Okay. Or you take sutures from these uterosacral, posterior peritoneum, then again uterosacral. Two sutures you take like that. Other sutures again from the these uterosacral, then posterior vaginal wall, then again uterosacral. Then you bring them out to the posterior and you tighten them. So this will close the posterior thing, right? So it will obliterate the posterior space, so that posterior wall of the vagina is tightened. So now it will prevent further rectocele or enterocele. So enterocele sac is excised and 3 modified Meckel stitches are placed. Each suture should incorporate the full thickness of the posterior vaginal wall, cul-de-sac peritoneum, remains of the uterosacral cardinal complex bilaterally, and the fascia tissue lateral and posterior to the upper vagina and rectum. These stitches fix the prolapsed wall to the uppermost portion of the endopelvic fascia. So basically, it tightens the posterior wall.
That only for posterior wall
Yeah,
prolapse?
it is only to prevent posterior wall prolapse because it is tightening only the posterior wall. And Moskowitz repair it is also the same thing, but you take a purse string suture. You take the vaginal wall, then Meckenrot and cardinal ligament, then again vaginal wall, then other Meckenrot, uterosacral, then posterior vaginal wall, and then you this ligate. So if you take it, rather than taking like these 3 different sutures, you take one continuous suture like that in a form of purse string. It is Moskowitz repair. Meckel caldoplasty is better than this Moskowitz. That's what. Okay. So this is even
Because what is that mark over something? In that only is single suture.
only single suture.
It may not withstand.
Okay, then the other thing that you can do, you can suture the cardinal and the uterosacral ligament to the vaginal cuff. So once you have removed the uterus, so you have various stumps. You have how do you remove the uterus? You cut all the supports. So above you cut the round ligament, then you cut the these broad ligament, then Meckenrods and uterosacral ligaments. So Meckenrods and uterosacral ligaments, they are down. So these ligaments you suture to the vaginal cuff. So these ligaments which were initially supporting the uterus now will support the vaginal cuff. So that you do. Okay, so this you can do at vaginal hysterectomy and also at total abdominal hysterectomy. This is high circumferential obliteration of the pouch of Douglas, and they minimize subsequent apical wall prolapse. Okay. So, and the other things that you can do, you can vaginal uterosacral suspension. So in this only uterosacral ligaments are sutured to the vaginal cuff. That support the vaginal cuff. And on the last thing is sacrospinous fixation. Sacrospinous fixation is this, where you fix the vaginal cuff to this sacrospinous ligament. There are 2 sacrospinous ligament. You fix it to this. So that it is supported by this ligament and it doesn't come down. Okay. So this is performed when vault or the point C on the POPQ system could be pulled to the introitus at the end of the upper anterior vaginal wall closure. So all these things you can do to prevent further vault prolapse after hysterectomy. Okay. but there is no role of doing subtotal hysterectomy. So it doesn't make sense that you remove only a part of the uterus, and in order to protect these ligaments you leave the you leave a lower part of the uterus. So that is not recommended.
And how does it help actually?
What?
No, like in subtotal hysterectomy.
It is not recommended. It will not help much. So this is not recommended. That's what they're saying.
No, even ligaments will be preserved.
So they will support. People think that they will support the vault and vault will not come down, but there are other things, like there can be need for subsequent surgery, cervical cancer screening you have to continue. So
Okay.
that's why it is not recommended at all.
Okay.
Okay. Although subtotal hysterectomy is quicker to perform and there are fewer intra and post-op complications, more women suffered with urinary incontinence and prolapse compared with women who had total hysterectomy. So complications are more with subtotal. So it is not recommended. Only these 5 things you can do to prevent. Meckel, suturing the cardinal or McEnroth's to uterosacral to the vaginal cuff, suturing the uterosacral to vaginal cuff, or sacrospinal fixation.
And how this may cause urinary incontinence when people go for
By
subtotal
irritation
hysterectomy?
or by injuring the wall, injuring the bladder.
Okay.
Then last is Lefort's operation or colpoclesis.
Mm.
So this is recommended in patients who are not sexually active at all and
Okay.
who are medically unfit for surgery. You cannot remove the uterus in those cases, those patients. So what you do, you oppose the two walls of the vagina. If you completely obliterate the two walls of the vagina, then uterus will not come down. Nothing will come down, right?
Okay.
So that is
In
total cause.
cases where they cannot go for hysterectomy.
Yeah, they're medically unfit for
Okay.
surgery
Okay.
or
Just
repair.
approximating the walls.
Just you oppose the wall. Okay. So if
Okay.
you totally oppose the wall, that is total colpoclesis. Okay.
Okay.
Partial colpoclesis is where what happens if you totally close. What is the problem? There are vaginal secretions which are secreted. So it can get accumulated and cause infection. So preferred is partial colpoclesis where some part of the vaginal epithelium is left unsutured to
Mm,
provide drainage of these secretions,
mm,
which is
mm.
in women with, to drain the cervical secretion so that infection doesn't develop. Okay.
So in total colpoclasis, total obliteration.
Yeah.
In partial, there is
Some
some part
space
of
is
vaginal
left for
epithelium.
the drainage of the cervical secretions.
Like how to choose between the two, which one to go for?
Partial is better, obviously, because otherwise, if you do total, no, there can be infection.
Okay, okay, because everything is accumulated inside, collected inside.
Uh, okay. So this was about.
And ma'am, I have a doubt.